And allow me to introduce our first speaker. Dr. Mohit Kara is a urology specialist in Houston, Texas, currently a professor in the Scott Department of Urology at Baylor College of Medicine. He specializes in male and female sexual dysfunction and hormone replacement therapy. Dr. Kara also serves as the director of the Laboratory for Endourology Research, the medical director of the Baylor Executive Health Program, and the medical director of the Scott Department of Urology. Mohit earned his undergraduate degree at Vanderbilt University and his master's degree in business administration and master's in public health from Boston University. He received his medical degree from the University of Texas Medical School in San Antonio and completed his urology residency training in the Scott Department of Urology at Baylor College of Medicine. Please help me welcome Dr. Kara.
Thank you so much.
How are you? Good to see you.
Good to see you. This is my clicker?
Yes, here.
Wonderful. Well, thank you very much for the invitation.
Please, 1 second.
Sure. Is this a microphone?
This is the one that's recording.
Oh, wonderful. Thank you very much for the invitation. This is my second opportunity to be here, and I really appreciate the opportunity. So I'm a urologist. I specialize in men's health. I actually specialize also in male and female sexual dysfunction, but most of my research over the past 10 to 12 years has been on testosterone replacement therapy and stem cells. And so one of the big things that most of you do is prescribe testosterone, right? And that's a very common thing. But you have to understand that there are certain controversies associated with testosterone. You may have heard of the controversy with heart attack, DVT, prostate cancer, infertility. How do you manage and deal with these controversies when you treat your patients every day in the clinic? And that's what I'd like to share with you today. So let's get started.
You're on.
I'm on. Thank you so much.
Sorry.
No problem. These are my disclosures. I do consult for several companies that do make testosterone products. So I'll start with just a little bit of history here. So did you know that in 2012, testosterone was the fastest selling medication in the United States? There wasn't a single medication in the US that was selling faster than testosterone. And the rate of sales growth was that the companies were doubling their sales every 33% per year. So every 3 years they were doubling. But there was a very interesting phenomenon that was occurring. And if you look, that the use of testosterone was skyrocketing, but towards the end, the testing was going down. And this got the FDA very concerned. And so in 2015, there was a report that came out that showed that roughly 27% of Americans who were using testosterone never had a blood test prior to initiating testosterone therapy, which is quite concerning. What's also very concerning is that roughly 21% of men who initiated testosterone therapy never had a follow-up blood test after they started. So clearly there was some concern for abuse. And this use of testosterone seems to be more of a US phenomenon because we didn't see such a resurgence in other countries such as the UK. So what are the controversies? There's three ways I want you to think about this. I want you to think about this in terms of what the FDA has in the package insert. So remember that patients are quite intelligent. What many of them will do is they'll read the package insert and they'll say, look, I read this in the package insert. Can you please explain this to me? But you also have to understand what the guidelines say. And two major guidelines came out in 2018. The American Urologic Association came out with their testosterone guidelines, and the endocrine guidelines came out with their third iteration of the testosterone guidelines. So it's important to know what all three of these bodies of literature have to say and how they differ in each of the topics we're going to discuss today. So the first topic we're going to discuss really is VTE, or venous thromboembolism. I can't tell you how many times I've heard a physician call me from, an internist call me from the hospital and say, look, we did a workup. This patient had a pulmonary embolism. He's on testosterone. We cannot find any cause for his workup. We believe it's the testosterone, and we want him to stop the testosterone. And my response is, on what basis are you saying this? What literature do you have to support this? And there's no data to support that claim. The data is extremely weak, and I'd like to show you that today. You should all be aware that early on in 2005 and 2009, the FDA did put in the package insert that there were patients, one patient in the on-label extension study that had a DVT, and they did put on the package insert in 2009 that blood clots in the legs are among serious side effects. Again, limited to no data or convincing data to support this. After that, in 2014, they actually put another statement in the package insert, which you should be aware of. This basically says that there have been reports of VTE, including DVT and PE, using testosterone products, in this case, such as androgel. And if evaluate patients who report symptoms, such as having a DVT, but the most important line is that if you suspect a VTE, discontinue use with androgel and appropriate workup and management. So what is the FDA saying? If a patient has a suspected DVT, stop the testosterone. Clearly that's what it says. So you should be aware of that. That is in the package insert. The patient will say, doctor, I read that if I have a DVT, I should stop the testosterone. Now, what do the AUA guidelines state? So just let me backtrack. What are guidelines? Guidelines are when a group of experts sit in a room and look at all the body of literature that they can find on this topic, and then come up with guidelines based on levels of evidence. What does the literature support? What does it not support? The AUA put out the testosterone guidelines and said, look, patients should be informed that there is no definitive evidence linking testosterone therapy to a VTE, period. No evidence. And this is based on a moderate recommendation. They give grades, moderate recommendation. The endocrine guidelines say, we're not sure. It's inconclusive. We need more studies to be done. So you have three bodies of literature, the FDA package insert saying, stop it, it causes a DVT. The AUA saying, no, it doesn't cause a DVT, and the endocrine guidelines saying, we're not sure, right? Very confusing, not only for patients, but also for clinicians on where we stand with DVT. But most of the data will suggest that it does not cause a DVT, or really that, I think the endocrine guidelines really say it's inconclusive because they feel like more studies need to be done. The one that's more controversial is heart attack, cardiovascular, right? And so I'll put this in the context of a story. In 2006, Molly Shores was one of the first to show in her study, it was retrospective, that those men with lower testosterone levels were much more likely to die at an earlier age. And she showed that if you look at the survival, this is a VA study, if you had low testosterone, you had decreased survival in follow-up. But after her study, there were numerous other studies. These were all prospective studies, larger studies, looking at men who had low testosterone levels, and these studies found the same thing. Very interesting. If you have lower testosterone levels, you're much more likely to die at an earlier age. And the cause of death, if you look at the right-hand column, is that many of these women were having heart attacks. They were having heart attacks, but with lower levels of testosterone. At the same time, before 2010, there were many studies suggesting that if you give men testosterone, you may decrease their risk factors for cardiovascular events. Risk factors meaning obesity, metabolic syndrome, diabetes, right? But something very interesting happened. We looked at all the articles we could find. This is a study we published from 1940 to 2014. We found 200 articles looking at testosterone and cardiovascular risk. And 4 studies suggested that if you give testosterone to men, you increase their risk for heart attack out of the 200. 4 studies suggested that. The majority of the studies said that no, low testosterone increases your risk for heart attack. Normalizing testosterone may decrease your risk for heart attack. These were the 4 studies, and if you follow the literature, if you follow the media, these 4 studies received a tremendous amount of attention. Most commonly the Vigan study in 2013, the Zoo in 2013, and the Finkel in 2014. And these 3 studies over here were very close together in time, from 2013 to 2014. So the FDA really had what I say is mainly a meeting in 2014 to discuss these trials. I would say that there's significant limitations to these trials. Not randomized, not placebo, no placebo. The Finkel study has no control. But these studies did suggest that there may be an increased risk. Because of these 4 studies in 2014, you should know that the FDA put a change in the label. And the label now says that there's inconclusive evidence to determine the risk of MACE in men who take testosterone. Patients should be informed of this possible risk when deciding whether to use or to continue to use. So again, if you have someone on testosterone, you should be telling them, do you want to continue to use based on this concern? And if you're going to start someone on testosterone, they say you should at least tell them of this possible risk. based on 4 studies that I showed you, not the other 200 that suggested there's no increased risk. Now, we realize that also that the EMA, which is very similar to the FDA, looked at this data and said we are not going to put any changes in our package insert. After this FDA change that occurred in 2015, myself and several colleagues also did another literature review. Every article we could find, we found 23 more studies, all suggesting no increased risk of testosterone and cardiovascular risk. In fact, those men, again, who normalized their testosterone had a reduced risk of death compared to those men who failed to normalize their testosterone. So the best way I can explain this to my patients is it's like a blip in time. So for many years, we showed that testosterone may be protective. Then from 2010 to 2014, we have just 4 studies suggesting there may be an increased risk. And then from 2014 to 2017, again, showing no risk at all. And that's where we are. That's what the data suggests. What do the guidelines say? The AUA guidelines, and they're pretty strong with this, say that clinicians should inform testosterone deficient patients that low testosterone is a risk factor for cardiovascular disease. Period. Strong recommendation. You have a patient that walks into your office and they have low testosterone. You are obligated, you should tell them, did you know, Mr. Smith, that low testosterone is an increased risk factor for cardiovascular disease? However, the second bullet, prior to initiating treatment, clinicians should counsel patients that at this time it cannot be definitively stated whether testosterone therapy increases or decreases the risk of cardiovascular events. And that's also a moderate recommendation. But this makes no sense for the patient. So I said, Mr. Smith, did you know that your low testosterone can increase your risk for heart attack? But by the way, if I give you testosterone, you can also get a heart attack. You can't win. It's a lose-lose, right? It's very confusing, but that's what it's saying. Now, the key thing for you here is that you should know that if someone does have a heart attack, the AUA guidelines want you to wait 3 to 6 months before you start testosterone. The endocrine guidelines say you must wait 6 months, right? So if someone says I had an MI, he comes in 6 weeks later, says, can I start testosterone? You say, no, wait a minute. You have to wait at least 3 to 6 months. If you want to be more conservative, you can go with the endocrine guidelines, which says wait at least 6 months before you reinitiate testosterone therapy. So these are the AUA guidelines, and the patients meet criteria for testosterone replacement therapy. I think this statement's a little bold. On the next one, they should have a cardiovascular risk assessment, and patients who are increased risk for cardiovascular events should be referred for further evaluation. So again, that's in our AUA guidelines. So the FDA had asked industry to do a large study. They said in 2015, said, look, you have a large study in women called the Women's Health Initiative in 2003, looking at estrogen and cardiovascular risk and breast cancer. But we do not have a large study in men. So we would like to have a large study in men, 6,000 patients, randomized placebo-controlled trial, and this study has already been started. I'm one of the 9 PIs that are running this trial, and this study is a 5-year trial, and we will be finished in June, roughly, of 2022, hopefully. This study is called the TRAVERSE trial. It's the largest trial ever, randomized placebo-controlled trial in men looking at testosterone and cardiovascular events. Secondary endpoints will also be looking at prostate safety and prostate cancer, but we'll also be capturing sexual function, depression, anemia, bone fractures, and diabetes. So it's an amazing study, another 2.5 years to come out, but it will offer a lot of value to the literature. I want to comment on erythrocytosis because one of the mechanisms for why it's believed that men have cardiovascular events is because the hematocrit goes up. And so we do know that men who take testosterone do see an increase in hematocrit, and it's really contingent upon what type of therapy they're taking. The injectables can have anywhere from 40 to 67%. This was our study that we published in 2015. We had men on injections, pellets, and gels. Roughly 66% of men on injectables had erythrocytosis. Typically, it's older patients, right? So older men on injectables expect a higher rate of erythrocytosis. And that erythrocytosis doesn't show up in a week or a month. On average, it shows up at 3 to 6 months. So you don't want to check the blood count too quickly. So at 3 to 6 months, but then it typically plateaus, right, wherever it is. And so if you have a man on an injectable and he's getting erythrocytosis, you can switch him to a gel. That's pretty smart because you'll drop it. If you have a man on an injectable or any kind of form of therapy and they get erythrocytosis, the key number is 54, because in the guidelines that 54 there may be an increased risk for cardiovascular events, and medical legally that's what the attorneys look at, 54. So in our clinic we start having them donate at 51 because we don't want to wait till 54, and we have them donate 2 pints of blood 1 week apart. You don't want them to do it the same day they get a little hypotensive, right? If they say, "Doc, I'm not allowed to donate blood," then you ask for a therapeutic phlebotomy. You can write the order. Any hospital has to take the order and throw away and discard the blood. But you have to get the blood off. The other option is to stop the testosterone, which most men don't want to do, or you can decrease the dose, which most men don't want to do. So again, therapeutic phlebotomy, you can change the modality of what you're using from injectable to gel. Make sure that if it's occurring frequently, you may want to get a heme consult, and also screen them for sleep apnea, because patients with sleep apnea are going to get a higher rate of erythrocytosis as well. We typically like to put them on an aspirin, a baby aspirin as well, if they're getting erythrocytosis. So I just want to make a comment that, we have these shared risk factors between hypogonadism and metabolic syndrome and cardiovascular disease, obesity, hypertension, dyslipidemia, insulin resistance. If a man develops these, he's more likely to get low testosterone. If a man develops these, he's more likely to get metabolic syndrome and a cardiovascular event. So it's not surprising that men who have hypogonadism are more likely sometimes to have a cardiovascular event because of the risk factors that they share. Next, I'd like to talk a little bit about indications for therapy, and this is very important. So when we treat men or women with a medication, we look at what the indications are on the package insert, and that lets you know if you're treating the patient on label or off label. For example, trazodone is an antidepressant, but trazodone is most commonly used, not for an antidepressant, as a sleep aid, right? So we use trazodone off label for helping men sleep. It is not illegal to treat someone off label, but many times you should be aware that you're doing this, and you should be counseling patients appropriately. In 1981, the testosterone label changed for all the products, and this is what the label said. It says androgens are indicated for the replacement therapy in the conditions associated with deficiency or absence of endogenous testosterone, and then it lists primary hypogonadism, and it lists medical conditions, cryptorchidism, orchitis, then it lists secondary hypogonadism, and then it lists things such as pituitary tumor. So let me be very clear, nowhere on this list do I see the word erectile dysfunction. Nowhere do I see the word low libido, right? So if a man comes in and he's 50 years old, has a testosterone of 180, has low energy, low libido, and I think is a perfect candidate for testosterone therapy, and he doesn't have one of these conditions listed, I'd say, well, then he has idiopathic. It's idiopathic, right? We don't know the cause, but he has idiopathic low T. He meets the criteria, I'm going to treat him. So the FDA slightly disagrees. So in 2015, the FDA put out a package put out a warning that cautions that prescription testosterone products are approved only for men who have low testosterone levels caused by certain medical conditions. The benefit and safety of these medications has not been established for the treatment of low testosterone due to aging, even if a man's symptoms seem related to low testosterone. So what are they saying? It has to be due to a true medical condition. So in that year, the FDA, this is the same package insert I showed you earlier, shows you that it has to be due to low testosterone, primary, secondary hypogonadism. They made a change to the package insert, and this is the change. The only change they made was that they took out the word idiopathic, right? They took out the word idiopathic. So now a patient must have one of those medical conditions to be considered on label. Right? To me, it doesn't make a lot of sense, because if a man has a pituitary tumor and has low testosterone, there's another man who has very low testosterone and does not have a pituitary tumor, both of them will suffer the same, and both of them will benefit the same when we give them back testosterone. But this is what's on the label. So how many of you are treating patients off label? It's actually a very interesting point. This is a study by Corona looking at over 4,000 men that came into the clinic. He said of these 4,000 men, roughly 20% of the patients that come in have low testosterone. Most of these patients have what we call secondary hypogonadism, meaning there's an issue with the pituitary. But look, out of those patients, 89% of those patients don't have a pituitary tumor. They don't have a true medical condition. Roughly 11% of those patients do. And if we do the math, I will just tell you that 85% of the patients that you treat today are off-label. 15% of the patients that you treat are on-label. But if you look very carefully at those patients who are off-label, they all have something pretty much in common. 71% of those patients have either diabetes, obesity, or metabolic syndrome. Diabetes, obesity, or metabolic syndrome. So these patients are real. These 85% of patients that are off-label, they're real patients. We see them in our practice all the time. We put them on testosterone therapy. Many of them have a significant improvement in their quality of life. How do you describe these patients? What's the name for these patients? So in 2016, we had a colloquium, which I ran in DC, where we looked at these patients and how we were defining them. We call these patients AOH, adult onset hypogonadism. And the key thing is that they're distinct from classical primary or secondary hypogonadism, meaning they don't have a testis tumor or a pituitary tumor. But the key point is that most of them have a chronic medical condition, such as diabetes, obesity, or metabolic syndrome. So I just want to make a comment on aging. So when I started my practice, I was taught that there's this concept called andropause, male menopause. And that's not true. People would use analogies. Just like women go through menopause and their estrogen goes down, men go through andropause and their testosterone goes down strictly by aging alone. That is not true. In fact, if you look at healthy men as they age, and I put the red line here, these are two different studies, healthy men do not have a significant decline in testosterone where they reach the hypogonadal range just to testosterone aging alone. It's the acquisition of comorbid conditions, obesity, diabetes, metabolic syndrome, opioid use, steroid abuse. These things then drop the T level down below the normal range. But aging alone does not significantly drop your testosterone. There's a slight decline, but not a significant decline to make you in the hypogonadal range. So what do the guidelines say? The guidelines say this is ridiculous. You don't have to have a true medical condition in order to treat. The guidelines state that you just have to have low serum testosterone and signs and symptoms of hypogonadism. That is consistent with the AUA guidelines, the endocrine guidelines, and numerous other guidelines throughout the world. Again, the guidelines state it doesn't have to be due to a medical condition, it's just low T and signs and symptoms. So again, low T and signs and symptoms, but this is a very important point because what I see many times in my practice is that patients come from the outside and they were started on testosterone and they had a starting testosterone of 450, 500, and they had symptoms. That's not a qualification for therapy. The flip is a guy comes in, his testosterone is 250, it's very low, and he says, I feel amazing. Why would you treat him? It doesn't matter about just the number alone. He has to have both signs and symptoms and a low serum testosterone value. So again, you must have both. The issue is this, is that many guidelines have switched the cutoff. The cutoff was 300 nanogram per deciliter, right? That number was arbitrarily made up, 300, right? But many guidelines say, okay, we're not going to use 300. We're going to use your lab's lower reference range. So if your lab's reference range is 250 to 900, the number is 250. If this lab's reference range is 280 to 800, the cutoff is 280. Whatever the lab's range is, we'll use that bottom number. That's what many guidelines will state. The problem is that there is complete variance. This was a study by Abe Morgenthaler's group out of Boston. He just called 25 labs on the phone. He said, okay, give me your lab's lower reference range. In some labs, the reference range was 130 to 450. So let me tell you where I'm going with this. If I walk into a lab that has a range of 130 to 800, and the patient walks in with a testosterone of 180, and I say, wow, you're really low. Let me start therapy. The insurance company calls me and says, I'm sorry, according to the new guidelines, he's normal, right? And we all know he's not normal. There's no way he's normal, but that's what the reference range says. And if a patient doesn't like his diagnosis, he can walk out of one lab and go to another lab, right? Get another blood test, and now he's in the hypogonadal range. So again, there's a lot of variability in using the lab's lower reference range as a cutoff. As I mentioned earlier, 300 was arbitrarily chosen. Many guidelines now use 350 as the cutoff. But again, 300 is an arbitrary number for where we choose. It makes no sense to me to say that everyone at 290 must feel bad and everyone at 310 must feel good. It doesn't make any sense, right? It's a range. And we know that every man has their own cutoff point. Some men actually feel fantastic at 250. Some men feel actually lousy at 350. So you have to have some flexibility in this number. One of the biggest controversies for years has been prostate cancer and enlargement of the prostate. And patients, I can't tell you how many times they Google it and say, I heard if I take testosterone, I can get prostate cancer, and I don't want prostate cancer. So where's the data? Look at this is a survey that went out to numerous countries in Brazil and Saudi and South Korea. And they asked these physicians, what is your number one concern? Why are you scared of giving men testosterone? And the physicians replied, I don't want to give them prostate cancer. That is my most common concern. I also don't want to make their urinary symptoms worse, because if I give them testosterone, it'll be harder to urinate with this medication. Where did this come from? This came from in 1941, a very seminal paper. You should pull this from Huggins and Hodges, that reported in that paper that if you reduce a man's testosterone, the prostate cancer went away. That's interesting. In that same paper, if you give testosterone, it caused prostate cancer to grow. Right? That's where it all started, this concern, 1941. But if you read this paper and you pull it from the library, you'll find that it was based on one single patient. One patient in 1941 is where this started. There's a very important study by Lenny Marks. Lenny Marks in 2006 did this study where he looked at a randomized, double-blinded, placebo-controlled trial, and he took men who had low testosterone, and he gave them testosterone, and he did a prostate biopsy before he gave them testosterone. He did a prostate biopsy 6 months after he gave him testosterone, and he wanted to look at changes in the prostate. What was happening to the prostate when I gave these men testosterone? So if you give men testosterone and you look at the blood, the serum, what do you expect? The testosterone goes up, the dihydrotestosterone goes up. That makes a lot of sense. But what he found was in the prostate, there was actually no change at all. It was called the prostate saturation model, meaning that the prostate could care less how high you raise the serum testosterone value. It only takes up what it needs, and then it's done. It's saturated. Right? So there was no change at all in the tissue, in the prostate tissue. So we were taught in medical school, and this is serum testosterone here, this is PSA and prostate growth here. We were taught that the line kept on going up, meaning the more testosterone I give, the greater the PSA and the greater the prostate growth. So it was a linear line. But that is not true. This line is curvilinear, which means that it saturates at a certain point. And many of us, including myself, believe that the saturation point is roughly at 250 nanogram per deciliter, right? So if a patient comes in and they have a testosterone of 280 and I raise them to 2,000, what should happen to the PSA? Nothing, right? Based on this model, right? If I take this same patient and I drop the PSA of the testosterone all the way to 0 with Lupron per se, the PSA should go to 0. So this is called the prostate saturation model, and you'll see why this is important. Shelley Bassine gave patients ridiculous amounts of testosterone, 600 milligrams of testosterone every week for 10 weeks. Their their testosterone shot up to almost 2,500. What happened to the PSA? No change at all. It's saturated. If you look at what we give when we give men an injection called Lupron, we spike up their testosterone temporarily and then it comes down. What happens to the PSA? No change in the spike, but when the testosterone starts to come down, the PSA starts to come down. It's probably the best example I can show you of the prostate saturation model. And then a study that I did in 2011 where I took men, 451 men, and I divided them into two groups, less than 250 testosterone, greater than 250 testosterone. The only patients that saw a change in their PSA were the patients that were less than 250 on their starting testosterone value. So this question comes up all the time. Hey, Dr. Kerr, if I start this patient on testosterone, is the PSA going to go up? I say it depends. If the testosterone starting testosterone is low, let's say it's at 200, I expect the PSA to go up. And the average change you should see is about 0.3 nanogram per deciliter, 0.3. That's consistent with the literature as well. If this patient's starting testosterone is 290 and you start them on testosterone, I don't expect to see much change at all, right? So it depends on where you're starting to assess how much change you're going to see in the PSA. We were again taught that low testosterone is good, high testosterone is bad for prostate cancer, but the literature is completely the opposite. The literature would suggest that low testosterone is associated with higher prostate cancer volume, more aggressive disease, higher chance for seminal vesicle involvement, higher chance for positive surgical margins. It's the opposite. Low testosterone seems to be a risk factor for prostate cancer aggressiveness and occurrence. But there, in the past 15 years, has been a very major paradigm shift, which I'd like to share with you today. As I mentioned to you earlier, in 1941, we were taught that testosterone was dangerous, and that dogma existed for decades. But over the past 15 years, we were first seeing that testosterone may be dangerous. When I finished my fellowship, we thought, hey, maybe it's safe. Maybe it could be safe. But then it got very interesting over the past 4 to 5 years. Maybe it's therapeutic, or maybe it's protective. Interesting thought, because that's a 180, right? Literally 180 way of thinking about testosterone. But let's look at why people would say this. When in 2003, when Abe Morgentaler came out with his first paper on high-grade PIN, this is not patients who have prostate cancer. These are patients who have a risk factor for having prostate cancer in the future. He showed that in this small series, 55 men benign, 20 men with high-grade PIN, no man had a recurrence, no man had progression of disease. And in 2003, which was about 16 years ago, this was a very bold study, because these were men that did not have cancer. They had a risk factor for prostate cancer, and they said to Dr. Morgentaler, how could you give men who have a risk factor for prostate cancer testosterone? It was a very bold study, but this is just 16 years ago. After that study, there have been numerous studies, we've published many as well, looking at giving men testosterone after radical prostatectomy, prostate cancer surgery. The majority of studies showing that there's no biochemical increase in biochemical recurrence. Some studies said it had a few biochemical recurrence, but many are trying to look at this giving testosterone after prostatectomy, still seeing not a significant increased rate of biochemical recurrence once we start them on testosterone. We did the largest study on radiation, so we give a lot of men testosterone after radiation, brachytherapy. This was about 100 patients. We did have a few patients, 6 patients out of 100 have a biochemical recurrence. The majority of these patients were on androgen deprivation therapy or unknown. So remember, when you give someone androgen deprivation therapy, you shut their testosterone down and you put their PSA down to 0. Now the patient walks into your office and you put them on testosterone therapy because you want to start them back up again. Remember what we just talked about, the prostate saturation model. If I put them back on testosterone, what's going to happen to the PSA? It's going to go up, right? It's going to go up. And if you don't know about the prostate saturation model, you're going to say he has a recurrence, but he doesn't have a recurrence. His prostate's just getting back to its euvolemic state where you're putting the normal testosterone. So again, many of these, I think, androgen deprivation patients actually were just seeing a manifestation of the prostate saturation model. So we actually did the first study looking at active surveillance. So as you know, many men in the United States are no longer getting surgery or radiation for their prostate cancer. Many men are undergoing a concept called active surveillance. Why? Because we know that roughly 97% of prostate cancer, which is low grade, is clinically insignificant. So we know that if a man walks in with 1 core Gleason 3+3, he would be better served watching him as opposed to taking out his prostate or radiating him. So we looked at many of these men and we gave them their testosterone back, and they're on active surveillance with active prostate cancer diagnosed on biopsy. These are men particularly with Gleason 3+3. We followed them for 24 months. What did we find? There was no change in PSA, no change in prostate volume, and no progression of disease. But in 54% of these patients, when we rebiopsied them, we couldn't find the cancer. So what's the point here? The point here is this. The risk of occult prostate cancer in the community is 1 in 6. In fact, many studies showed on autopsy in the morgue, 1 in 3 men have prostate cancer. It's a lot of men walking around with prostate cancer, but they will never know it. They will die from something else. And we know that if you in your practice are treating 60 men per se with testosterone, I promise you that you're treating 10 men with active prostate cancer. I promise you, there's no choice. These 10 men are getting, with active prostate cancer, are getting testosterone, but they're not lighting up. There's never been a single study to show that those men being treated with testosterone have a higher incidence of prostate cancer than those men not being treated with testosterone. So again, we basically wrote in our conclusion that we are only doing openly what many of you are doing blindly in your practice. We did not see an increased risk of prostate cancer progression in these men on active surveillance. So there are numerous studies, I'm not going to go into these, looking at the concept of low T as a risk factor for biochemical recurrence. So at the end of the day, if a man walks in and he has prostate cancer, many studies say check the testosterone level. If the testosterone level is low, don't put him on active surveillance, because that is a risk factor for progression. If the testosterone is low before you take out his prostate, that's a risk factor that he may get a biochemical recurrence. So now testosterone is considered a risk factor, low testosterone, for who's going to get a recurrence of their prostate cancer, who's going to go on to progress to more aggressive prostate cancer. This was the study that we published in 2003 that got a lot of attention. I'll tell you why. So in 2013, we looked at 103 hypogonadal men and they were treated for radical prostatectomy. We had a control group of 49 men who had normal testosterone. But we did something kind of unconventional. We gave a lot of these men testosterone who had very aggressive disease, Gleason 8, positive surgical margins, positive lymph nodes. And what we found was that there were some recurrences in prostate cancer, but they were only in men who had high-risk prostate cancer. And if you received testosterone, the recurrence rate was 15%. If you did not receive testosterone, your recurrence rate was 53%, which is kind of odd, right? The recurrence rate was lower if you received testosterone. And so when we submitted the paper, it got accepted. The editor said, are you suggesting in any way that testosterone may be protective because your recurrence rates are very low in this high-risk population? So there is data, I will tell you, there is data, even basic science data suggests that testosterone may be protective. When you give testosterone to cells, it tends to cause those prostate cancer cells to die. And this is one of the most amazing studies. So I've talked to you about this 15-year revolution that's occurring. In 2015, Dr. Denmead published a landmark paper. Do you know how they treat men with metastatic prostate cancer at Johns Hopkins today? If I had metastatic prostate cancer spread throughout my body, I would walk into Johns Hopkins and they would treat me how? By giving me high doses of testosterone. FDA approved, IRB approved study that's been shown to be very effective, right? Can you imagine? So these are 14 men with castrate-resistant prostate cancer, high doses of testosterone. We call this bipolar androgen therapy, or BAT, where the levels go up, then they come down. They go up and they go down. What did he find? 50% reduction in PSA, 50% reduction in metastatic disease. Unheard of to do this 15 years ago, right? But this is what they're doing today at Johns Hopkins. In fact, his second study, looking at 29 men who had actually a PSA recurrence. So they had radical prostatectomy, they had biochemical recurrence, low metastatic burden. He wanted to look at the PSA at the end of 18 months, and at the end of 18 months, roughly 60% of patients did not have what they considered an elevated PSA. And what did he also find? They felt better, right? You put these men on testosterone, their quality of life improved, and their erectile function improved. The reason I show you this study is, again, this is how they're treating patients with metastatic prostate cancer today at Johns Hopkins. So in my lab, I have a basic science lab at Baylor. We do a lot of work with prostate cancer cells and testosterone. And so we did some very similar studies. We took Petri dishes, and in the Petri dishes, we put different concentrations of testosterone. And these Petri dishes were filled with Lynn-cap cells, which are prostate cancer cells. So if you look, and I'll just show you any one of these, this is with 0 testosterone. As we put testosterone in the Petri dishes, the prostate cancer grows. That is true. The prostate cancer initially likes the testosterone and it grows. But as we put higher and higher doses of testosterone, we see greater and greater suppression of prostate cancer cell growth, right? So we term this phrase the inverted U. The inverted U meaning there may be some benefit in castrate, there may be some benefit in having a patient in the normal eugonadal range. The danger zone is the hypogonadal range, in my opinion. Looking at those cells again, this is no testosterone. These are prostate cancer cells. I give a little bit of testosterone and they like it, right? They start to grow. I give higher and higher doses of testosterone and those cells are suppressed. Again, an example of the inverted U. So after we finished this study, we said, well, this is in vitro. Why don't we do some animal studies to see if this also is true? So what we did was we looked at almost 200 mice. And we took these mice, we had control mice, we had mice that we did orchiectomy, removed the testosterone, removed the testicles. Then we did orchiectomy plus low-dose testosterone. Then we did orchiectomy plus high-dose testosterone. And we injected prostate cancer cells in the back of all the mice, and we followed them for roughly 3 months. So these are the small pellets of testosterone that we place subcutaneously under the skin. This is prostate cancer that's growing on the back of the mice, and we can measure the amount of tumor that's in the back of the prostate cancer on the mice. So what did we find? So these are control groups. If you take away testosterone and you castrate, it is very protective. That is true, it does help. If you give them low-dose testosterone, it's not good. The cancer is almost as bad as the control group. But what happens when you give high doses of testosterone? You see a significant suppression in prostate cancer cell growth. Again, the exact same inverted U. So my personal bias, my take-home, is that a patient walks into me and says, I have low testosterone, I had a radical prostatectomy, what should I do? I said, if I was you, I'd either castrate yourself or get into the normal testosterone range. But I personally don't believe that staying in the hypogonadal range is safe. And the castrate can be chemical castration with Lupron, but again, you don't want to be in the hypogonadal range. So I started a randomized placebo-controlled trial, and this was many years ago, looking at men who've had a radical prostatectomy. And it took a long time working with the FDA to get approval. The FDA initially wanted me to wait 1 year. I was able to convince them to let me start as early as 3 months if I have 2 undetectable PSAs. And the reason being is because we firmly believe that the recovery of erectile function after prostate cancer surgery is in the first 6 months. That is the critical window. Testosterone has to be within normalized. Rehab should be started within that first 6 months. And numerous other studies have shown also the critical window is 6 months. So waiting a year doesn't offer me any benefit when it comes to recovery of sexual function. So the package insert says that you should not use testosterone in men with prostate cancer. That's in the package insert. But the guidelines came out with something very nice this year. The AUA guidelines said that clinicians should inform patients of the absence of evidence linking testosterone therapy to the development of prostate cancer. Strong recommendation. And finally, I can tell my patients, actually, did you know that the AUA guidelines came out last year saying that there is no link between testosterone and prostate cancer, period? Right? Finally, because before this came out, I would just tell them the literature doesn't support it, there's no data to support it. Now we have a guideline statement saying patients should be informed. There is no link between testosterone and prostate cancer, period, right? And that's a strong recommendation. The issue is if they have a history of prostate cancer, like radical prostatectomy, radiation, the guidelines state that we're not sure if it's safe and the risk-benefit ratio has not been established. So again, if they had a history of radical prostatectomy, again, the guidelines say inadequate evidence, but if they haven't had any prostate cancer, no data to support the link. So this is why I think this is a complete change in paradigm, because I said that 15 years ago we thought it was dangerous. I showed you the A. Morgenthaler study in 2003 that with men who didn't have prostate cancer but may have a risk factor for prostate cancer, they thought he was crazy in 2003. And now, if you look at, these are physicians, these are Canadian urologists, they got a questionnaire. They said, tell us your comfort level of giving testosterone to men with prostate cancer. So it says, is it safe to give testosterone to men who have had prostate cancer after radical prostatectomy? 96% say yes. Is it safe to give it after radiation? Yes, 84%. Is it safe to have brachytherapy? 86%. Would you offer testosterone to men who have active surveillance for prostate cancer? Look at that. The paradigm just in 16 years has significantly changed, and the confidence in many physicians in prescribing testosterone has changed very rapidly just in these past 16 years. The second thing about prostate you should know is that the first line in the package insert says that patients with BPH treated with androgens are at increased risk for worsening of symptoms of BPH. That's very important. Monitor patients for BPH and worsening signs and symptoms. Where is this data coming from? there's not a single study, a convincing study, I would say, to support that testosterone makes urinary symptoms worse. It is true that the body needs to see testosterone in order for the prostate to grow in a fetus. So in a fetus, if a fetus does not see testosterone, the prostate doesn't grow. But that is not true in the adult male. That is not true in the adult male. In fact, if you look at the best study I could find by DeLay and Kohler, they went through every article they could find on testosterone and BPH, lower urinary tract symptoms. And if you look at the right-hand column, what did they find? They found that testosterone either doesn't affect the prostate at all, or over time makes urinary symptoms better. Makes it better. Testosterone is a very strong anti-inflammatory, and if over time, many patients report an improvement in urinary symptoms. This is a complete 180 of what we see in the package insert. So I want to bring up another concept about disease modification, because there's a very interesting thing that internists do. So if I walked in to see Dr. Slayman today and I have elevated cholesterol, and I'd say, look, I have a problem, he'd say, look, I want you to do diet and exercise. I want you to really try to modify your lifestyle. And if it doesn't work, I'll give you a statin. That's what he would say to me. He wouldn't just give me a statin without giving me some education on diet and exercise and lifestyle modification, right? So why do we do this with testosterone, right? So when a patient walks in and they have low testosterone, why do we always reach for the pill and reach for the medication? Is there any benefit in lifestyle modification in these patients first? And if that doesn't work, then we would go on to giving them the medication. Because historically we're taught low T, just give them the injection right away. So there is data to support, good data to support, that diet and exercise, improved glycemic control, weight loss, sleep, stress reduction, varicose vein repair, all significantly improve a man's serum testosterone level without having to give them the pill, right? Which is very important. There's some issues with this. So this is a study looking at just diet and exercise. And if you look at diet and exercise alone, 12-week program, obese men, aerobic exercise and diet, they did see a statistically significant improvement in their serum testosterone. But it wasn't clinically significant, right? 25 nanogram per deciliter doesn't mean very much when you're treating men with testosterone. So it's not about the diet and exercise, it's really about how much weight do you lose. And the best study I could find was the Camacho study from the European Male Aging Study. What a great study. So look at this. If a man, it's a bidirectional relationship. So if a man loses 10% of his body weight, he sees an 85 nanogram per deciliter increase in the serum testosterone. And if he gains 10% of his body weight, he's actually going to lose 85 nanogram per deciliter and serum testosterone. But the line is not linear, it's curvilinear. Because if he loses 15% of his body weight, he gains almost 270 nanogram per deciliter in his serum testosterone value, 270, which is very, very significant. And the vice versa, if he gains 15%, he loses 270. So it's a bidirectional relationship, and obesity and weight loss are strongly correlated with testosterone. And the best examples we can give you are the patients who undergo bariatric surgery, right? It's a very sure way to lose weight. If you look at men who were on a low-calorie diet and lost 10% of their body weight, or if you look at patients who had bariatric surgery, lost 32% of their body weight, what did you see? Low-calorie diet, you gained 83 nanogram per deciliter. Patients with bariatric surgery, 250, that's a lot. A 250 nanogram per deciliter increase in their serum testosterone value. The problem we have with just diet and exercise alone is it's not sustainable. Many patients will lose 10 to 15% of their body weight, but then they'll gain it back, right? So the testosterone will then start to drop again. But bariatric surgery seems to be sustainable over time. Sleep is critical. It is critical for numerous factors, but it's also critical for testosterone production. Remember that young men, when they wake up in the morning, they have their highest levels of testosterone, and during the rest of the day, it tends to go down. This is called diurnal variation, right? That means they make their testosterone when they sleep. If they do not sleep, they do not make their testosterone. Sleep apnea has been historically known to cause a reduction in testosterone. Why? Because when you have sleep apnea, you decrease your O2 content within the brain. When the O2 content goes down, you decrease LH and FSH production from the pituitary, so you make less testosterone. This also affects fertility as well. If you do surgery like UPP surgery, if you give patients a CPAP machine, you may see a significant improvement in serum testosterone value. And that number is almost 100 nanogram per deciliter. So it's not negligible, it's something, but most studies will suggest that if you improve sleep apnea, you will improve serum testosterone values. But the most interesting one is sleep deprivation. So if everyone in this room, for 8 nights, we only gave you 5 hours of sleep every night, what's gonna happen? Your T levels will drop by 10 to 15%, no question. So if you deprive patients with sleep, the T levels will drop. What's interesting is that the second half of the night is more important than the first half of the night. So let's say I every night go to bed from 12 midnight to 8 in the morning. And for every night, I started saying, you know what, I'm gonna get terrible sleep from 12 to 4, but from 4 to 8 in the morning, I'm gonna sleep really well. That's great, because the second half of the night is more important, and I shouldn't see a significant reduction in my serum testosterone value. Let's say every night I sleep from 12 to 4, and from 4 to 8, I'm sitting up and waiting in the bed. My T levels will go down. The second half of the night is more important than the first half of the night when we talk about testosterone production. Stress is also a deal breaker. Remember that when patients are stressed, cortisol levels go up. Those cortisol levels suppress pituitary function and our ability to make testosterone and fertility as well. So there have been numerous studies looking at stress. I'm not going to go into them, but Andy Gay did a very nice study in 2010, and he found that if you look at reasons for why men have low testosterone, the risk factors were hypertension, tobacco, sleep apnea, and work stress. And he quantified work stress as the following: long hours, multiple jobs, long daily commute. These were independent risk factors for why patients would have a low serum testosterone value. Varicocele repair. So remember, varicoceles are dilated veins around the testicle. They can have 3 grades, 1, 2, and 3. And why is that important? The testicles have to be outside the body for a reason. They have to be 3 degrees cooler, right? Anything that increases the temperature of the testicle will decrease the production. The testicle only has 2 functions. It's sperm and testosterone. That's it, right? So if the temperature goes up, both of these come down. These dilated veins, what they do is they carry heat, right? They're dilated veins, they're blood, right? The temperature goes up, the production goes down. But what happens if you fix the varicocele repair? What happens if I fix the varicocele repair surgically? Some studies show that you'll see about 100 nanogram per deciliter increase in serum testosterone. Other studies, like a meta-analysis showing anywhere from 80 to 100 nanogram per deciliter improvement in serum testosterone values. So why is this all important? If an obese man walks in with sleep apnea and has a varicocele, if we improve his serum testosterone level, improve his obesity by just say 10%, if we fix his sleep apnea, if we fix his varicoceles, these all add up. 100 here, 100 there, 100 here, 300-400 nanogram per deciliter. Maybe he doesn't need to be started on serum testosterone. If I start you on serum testosterone today, I shut down your own natural production, and you're dependent on it pretty much for life, right? Why would I do that if there's an opportunity to actually make you produce it for several more years safely, right? So again, you just want to be able to counsel patients on natural ways to improve their serum testosterone. There's some amazing things that are occurring in the future for testosterone therapy. One of them is nanotechnology. We patented this technology with Methodist Hospital. It looks like a chip, and this chip is implanted underneath the side of the hip. The only problem is that the chip has to be taken out and replaced every 6 months, right? But what's really nice about it, if you look at this is over months, this is testosterone. Over several months, if you give someone a pellet, it goes up and it comes down. With the chip, we like to use the analogy of an hourglass. It's a slow, even decay over 6 months, right? A slow, even decay over 6 months. And so that's a very nice delivery mechanism. This is our earlier study with rats. So we did early studies. These are the chip with the implant. This is looking at the implant. This is looking at normal mice, and these are rats that have no testosterone at all. But we have a very nice decay, and it goes all the way out to, ours went out all the way out to 6 months. The second technology is Leydig cell and stem cells. So everyone knows what stem cells are. They're a cell that can turn into any part of the body. They're pretty amazing. We're using stem cell therapy now for Parkinson's. We're using it for many other conditions like leukemia. But we're now starting to use stem cells to treat men for low testosterone. if a cell can turn into any part of the body, and we know that Leydig cells in the testicle are responsible for making testosterone, we're now taking cells, making them into Leydig cells, putting them back into the testicle, and the man now once again makes his own testosterone, right? So pretty amazing. So I'm not giving you testosterone, I'm allowing you to once again make your own testosterone by using your own stem cells. So in conclusion, the diagnosis of hypogonadism can be challenging, but remember the majority of men we're treating today are off-label. Clinicians prescribing testosterone therapy should be aware of the AUA guidelines and the endocrine guidelines, and also what's in the package insert, because patients will ask you. Testosterone has been shown to improve BPH and lower urinary tract symptoms, despite what the first bullet says in the package insert, saying that it makes it worse, right? It's been shown to improve. Low serum testosterone has been associated with the risk factor for MI and cardiovascular risk. That's important. There's no convincing data to support that testosterone therapy causes prostate cancer. And patients should be appropriately counseled on the risks of VTE, CVE, BPH, and prostate cancer when prescribing testosterone therapy. Thank you for your attention. Thank you. I'm open to any questions or comments. Yes, please.
The first one is the incidence of MIs increases with low testosterone.
Correct.
And the testosterone is an anti-inflammatory. Can you explain more of that? The studies about being an anti-inflammatory, now that we know that a lot of the problems of the blood vessels are
Sure.
inflammation.
Sure. So it's a two-part question. So the first part question is low testosterone and cardiovascular risk. So the majority of studies show that men with lower testosterone levels are more likely to have a cardiovascular risk or an MI, right? And that's been actually in the guidelines. Now, what is the etiology? Is it the low testosterone in itself causing the MI? Maybe. Or is it an indirect association? Maybe the low testosterone is increasing your risk for obesity, diabetes, metabolic syndrome, which we know increase your risk for MI, right? So is it a direct effect or an indirect effect? Dr. Trace and many others believe it's a direct effect. Many others when we have these conferences we debate, say it's an indirect effect. But in either case, it's an effect, right? It's an association, right? And that may not be a cause, but it's an association. So again, I think it's very important to follow the guidelines, to let patients know, did you know that your low testosterone may be an increased risk for having a cardiovascular event, period. The second one is an anti-inflammatory effect. Testosterone has been shown to have an anti-inflammatory effect, particularly in the prostate itself. So remember, what is BPH many times? What is prostatitis? It's an inflammation, right? It's an inflammation of the prostate. So you would assume that long-term therapy with testosterone could be an explanation for why many of these patients see an improvement in their urinary symptoms over time, not a worsening. Now, I want to say one thing. If a man comes to me with a very low testosterone of, let's say, 150, and I put him on testosterone, if you remember the prostate saturation model, initially on low T levels, the prostate will grow a little bit. And initially, within the first 3 months, some men may complain of worsening of symptoms if they were starting at a low level. If the same man was starting at 290 and I put him on testosterone, I don't expect him to complain of worsening of BPH symptoms. But at 150, maybe, only at the beginning. And at the end of the 3 months, if you follow these men for 12 months, a very nice study by Dr. Hayter, Dr. Said, showed that then the levels start to improve. So you see a little bit of a bump initially for worsening, and then they continue to get better. But there is an anti-inflammatory effect associated with testosterone.
It is believed that it is statistically, but how does it work in the cell? Do we have any idea?
I couldn't give you an answer for how it works in the cells.
Thank you very much.
Sure. Yes.
So, in the setting of insulin resistance and in the setting of obesity, the testosterone gets converted to non-active intermediates. And so it's perhaps less effective. So that's one part. And the second part is what you already explained, is that the low testosterone may be a manifestation of many other factors. The relationship may not be causal, but associated.
Yes, sure.
And treating with testosterone may be like just sidelining and not treating the real cause, the root cause.
Right, but we do know that there's a bi-directional relationship with, for example, let's say obesity. If I give men testosterone, we do see a significant decrease in fat deposition, increase in muscle mass. no question, we do it. If it's true, and these are patients not allowed to exercise, it's just increasing testosterone decreases fat deposition, increases muscle mass. That in itself decreases your risk for an MI. Right? I mean, that's been shown. Right? So sometimes giving the testosterone, if it improves insulin resistance, that also decreases your risk for future MI. So giving T in itself may not be the reason why you have a decrease in MI, but maybe I'm improving your risk factors for an MI. Some actually believe that actually giving the T actually itself decreases the risk for an MI. I'm not sure I'm there yet, but I am there where it does decrease the risk factors for an MI. Yes?
Fascinating talk, Mike. Thank you.
Thank you.
So can you speak a little bit about two things? One is the effect of testosterone on testicular cancer in some function.
Sure.
You spoke a lot about prostate. And then is there any studies that you're aware of where people have used really long-term testosterone? I mean, I know that the Traverse will come out in a couple of years, but barring that, is there any, like, you know, a 10+ year or
Yeah.
20-year study to really understand, you know, the real
Sure.
benefits of replacement of testosterone, not therapeutic use of testosterone?
Sure. So two things. One is the testicular cancer. There's no data at all to support that testosterone causes testicular cancer, right? So that's not in the guidelines. That's not even the testis guidelines. That's not even the T guidelines. It's not even mentioned. We don't see studies looking at giving testosterone causing testicular cancer. So I feel very confident that that's not going to be an issue. Remember, what does testosterone do? It suppresses endogenous testosterone production. So it shuts it down, doesn't rev it up. Right, it's the opposite, right? So that's pretty safe. The largest trial, the best trial we have today is called the T trials. The T trials are 790 men. It was 12 months, randomized placebo-controlled trial. There were 7 trials in the T trials. That came out roughly in 2016, I believe. So the T trials, you may have heard of this, where they had the Budoff trial showing increased coronary plaque. That was the cardiovascular trial. Then they had the bone trial. It's a great trial, but it wasn't powered enough to look at cardiovascular risk. That was the problem. And so it showed no effect on vitality, showed no effect on physical function unless you combined all the men. It did show improvements in anemia. It did show improvements in bone function. So there were some things that benefited, some things that didn't, but there's only 790 patients. It's only 12 months, but it was a very good trial. It was a very good trial. Unfortunately, that's the best trial we have. That is the best trial we have in terms of randomized placebo-controlled trial. That's why the FDA in 2015 said, look, you know, you have this amazing study in women, the Women's Health Initiative, 10,000 women. I mean, you have nothing in men, and you expect us to continue to let you prescribe this medication and say that it's safe. You have to give us some safety data, right? So that's why this study was spawned. Sure. Yes, Joseph.
Thank you for this.
Sure.
Talk.
My pleasure.
Erythrocytosis, is there any difference by introducing testosterone sub-Q versus IM? And the other question is, handling the two. You know, we send sometimes our lab pick up in the afternoon, sometimes they pick up early. Does it matter? Is testosterone volatile in the tube? Can you please answer those?
Sure. So two things, erythrocytosis. Remember that the reason why we believe that men develop erythrocytosis is the spiking, okay? So if I give someone an injection and every 2 weeks I spike him like crazy, you better believe he's gonna have a higher risk for erythrocytosis. So then we said, okay, let's get clever. Let's go ahead and take, instead of 200 milligrams every 2 weeks, let's go to 100 milligrams a week. And what we found when we gave 100 milligrams a week instead of 200 every 2 weeks, same dose, is that the erythrocytosis went down. So I said, okay, now let's give them 50 milligrams twice a week, right? Same dose, but now splitting it in 4. And the erythrocytosis went down even further because I'm not spiking as much as I used to have. Remember, the half-life of these injectables is about 8 days. So at least for 16 days, you have a great level in these little tiny spikes. So because we're giving such a small dose at 0.25 cc's, 50 milligrams, we started giving sub-Q because it's so easy. So I don't think the sub-Q is dropping the erythrocytosis. I think the drop in dosage and the more frequent dosing is dropping the erythrocytosis. Now, for many years when we were giving sub-Q, we were doing it off-label because you're supposed to give it IM. But remember, 2 years ago, what came out was Xiasted. Xiasted is the first auto-injector that's given sub-Q. It's 1 cc of testosterone enanthate given sub-Q. So now it's on label, right? And so we tell patients it's on label because Xyostat is an on-label drug giving testosterone sub-Q. I think patients do better with sub-Q in the sense that it's less pain. And I think that it's easier to administer. And I think they do better when we give it to them twice a week. So we do Sunday and Thursday. Because remember, testosterone peaks in 24 hours. So if you do it Sunday, they feel great for the week. You do it Thursday, you feel great for the weekend, right? So it's a great split between the two. Your second question was on
the testosterone, the levels.
the levels.
Does it matter what time is the tube picked up?
Yeah.
After we
All we know is that if you remember the concept of diurnal variation, meaning that highest levels in the morning, less at night, in the afternoon, that diurnal variation is muted between the ages of 40 and 50. Between the ages of 40 and 50, so a 70-year-old man, it doesn't matter as much if you check it in the morning or night. I have never seen data on what time the tube is picked up. Many tubes are shipped out. If you have a central lab, they're shipped to Austin, they're shipped to other places, so, and many tubes are done internally. I've not seen if you hold on to the tube for a longer period of time, the T levels will drop. I have not seen that data. I have seen interesting data that if someone eats prior to the test, even though we told them it doesn't matter whether you're fasting or not, if you eat, it does drop your serum testosterone. There's good data to support that as well.
Okay, so if they're doing the shot on a Sunday and on a Thursday, when you ask them, they need to do a follow-up lab?
Yeah, so my important thing, so everyone has a different way of doing it. Some have always said, I want to check the testosterone 24 hours after he takes the injection. Let's say it's 200 milligrams every 2 weeks, 24 hours. I want to see how high he gets. Others, endocrinologists say, I want to check it in the middle. I want to check it, if it's a 2-week injection, I check it at 1 week. I personally like to check it at the trough, right? Because if I give them too much testosterone, typically there'll be other manifestations like erythrocytosis. But what I'm concerned about is at the trough. If the trough says 180, I know that for the 2 weeks, a good portion of it, he's feeling lousy, right? Because the trough is at 180. So I want my trough above 350, maybe above 300. I don't want the trough too low. So I check it at the bottom. So whenever he's about to give himself an injection, that day he comes in.
Awesome.
Yep.
Thank you.
Thank you very much. Sure. Sure.
How often do you check the hematocrit?
How often do I check the hematocrit? So if you saw the first slide, don't check the hematocrit early. Wait at least 3 months in order to check the hematocrit, but you don't want to check the hematocrit less than twice a year, right? So I don't want to wait a year and find out that he had erythrocytosis, no less than twice a year.